Bhimji, we talked about the shortage in terms of doctors, the lack of pay, you said, across the counties, the failure in the absorption of the doctors by, or the professionals by the counties. However, even as we talk about the health sector allocation, 146.8 billion, 6% of the GDP, 9% to fill that gap. And talking about the quality of life as enshrined in Kenya's Vision 2030 and Kenya's health policy 2012 to 2030, we are now about 8 years before we actualize, 7 years before we actualize that, in transforming Kenya into a global healthcare hub. I mean, how then certain are we that these achievements will be met with the current state of affairs?
To answer you, I'll just first go with what Dr. Kiragu was saying. You know, when we talk about the primary healthcare in the country, we focus only on the on not having the doctors in the series. But one thing that has come out that makes many of these patients to be undiagnosed or to be not identified in time is because you realize you can have a whole sub-county with no doctor at all. There's some of the sub-county is almost level of a district. So without that, or without incorporating doctors as part of the primary health care, within the community health care, within the clinical officers are there, with the nurses, then it would be very difficult to actually identify most of these cases. And they have to be referred to level 6 before they're identified. So that's actual need that is there. To answer you, I'll say that this actual need for us to see the model of healthcare that will work, we have to change the mentality of healthcare being a recurrent expenditure as a country and look at healthcare as an investment and a backbone for economy. But we have not looked into that. We look at healthcare as a recurrent expenditure, then the cost of the drugs, the cost of employing workers, the cost of employing doctors, nurses, and that makes the budget to be limited. In the whole of Africa, as of now, we have Rwanda and South Africa that have reached over 50% of the budget declaration. And you can see in the number of doctors, the number of healthcare workers they have in their country. For example, in South Africa, there was only 400 doctors that were not employed in the year 2022. A one-day march led to that employment within 2 weeks. Mm-hmm. So they have a workforce of healthcare workers with about 15,000 or about 16,000 doctors in public sector. But here we have about only 3,000, 4,000. So it's very difficult to equate the healthcare delivery in these two places. So there has to be an intentional plan to have human resource to run the healthcare.
Okay, but Dr. Bhimji, I wonder how intentional then the government is, because you talk about the protest in the Rainbow Nation, South Africa, which prompted the government to absorb in the doctors, 400 you said. Here we're talking about 4,352. There was the longest doctors' strike ever in history of nearly 100 days that paralyzed the healthcare system in the country. And then the government's failure to, or reneging on the memorandum of understanding that you signed with them, the organization that was then led by Dr. Ouma Oluga, and which of course you subscribe to. If that failed to prompt the government to absorb you, the professionals, and often a budget of about 3 to 4.5 million to train a doctor, and then the end game is doctors flocking out of the country for greener pastures or others committing suicide because of lack of employment, then what's the point?
If you looked at our notice that we gave to the government on November 28th, it was the intention to proceed on industrial action. And the whole issue was that we were not looking for money or for extra funds for the doctors or for the healthcare workers. Our intention was to have a functional healthcare for the Kenyans. That is it possible to go to the hospital and get the doctor, get the services, get the drugs, and get the laboratory services working. We have what you call an MOU where the COG and the ministry agreed to look into these matters. But even up to that, we have an appointment of healthcare workers, 514 healthcare workers. That advertisement was done. The appointment that was given to them December 2021. To date, they've not been employed. So that gives you the clarity that there has to be an action. And the action has to be deliberate by both the national government and the county governments. Or else there's much deliberate effort to make healthcare not to work so that the private healthcare can actually succeed. Mm-hmm. That also must be there, because you look into it that who then runs the private healthcare in the country? Who are the investors? Are they the same leaders who are in the cabinet? Are they the same ones who are in the parliament? Okay. Are they making policies that will ensure that we have excess of healthcare workers or doctors, not in the facilities, but outside, so that we can have a lower cost of employing them from the private sector? Those are things that we need to look into. And that's why, as a union, we are saying that if, in case we call for an industrial action, to have doctors employed. It is not for the doctors, it's for the Kenyans.
Okay.
So that the healthcare can actually function.
Thank you.
All right.
Yes.